much. Greg is the too much guy, defending that we should image people, and Jens is going to defend that we just need a plain CT. We don't need anything else. So fight is on.
Too much guy. You said, you never told me when you asked me to give this talk, was I too little or too much? Too much would be we don't need to do imaging. So that's the less is more approach. And I was thinking about doing that, but I figured, you know, what's Tudor going to do? And you would think that Tudor might say you need imaging because his Dawn study was an imaging-based study. It was a huge home run. But in any case, let's see what we can get to here. Just to go over disclosures, we developed the Rapid software at Stanford over many years, and then it was sold to a SchemaView. For Medtronic, at the time they were Covidian. We were running the penumbral imaging core lab for Swift Prime, and then I'm the PI for the Timeless study, which is the TNK versus placebo trial that we talked about earlier, and that is being sponsored by Genentech. Okay, so I'm going to talk about too little imaging, that there's too little imaging. We should do penumbral imaging in most of these patients. And the lawyers have a term called res ipsa loquitur. Do you guys know what that stands for? Any law students here? I think it directly translates to saying the evidence speaks for itself, okay? So this is the results of these modern thrombectomy trials looking at the absolute benefit. And you can see we've had a number of positive trials, but the ones that have big benefits, very large benefits, are the ones that did perfusion imaging. So this is a little introduction to the idea that I think perfusion imaging has a lot to offer. Yet, there have been criticisms, and I suspect we will hear some more criticisms today. During most of my career, I was criticized because my trials did not produce very good results. And now I'm being criticized because the trials I've been involved with have results that are too good. So you just cannot win around here. And specifically, people are very focused on the NNT from Dawn and Diffuse 3, saying, wow, an NNT of 2 or 3, that's bad. That is a bad NNT because it proves you're excluding a lot of patients who could benefit. So we're going to talk about what the NNT should be. And then sometimes we hear people, Tudor, for example, say endovascular therapy can be futile but never harmful. So we'll talk about that a little bit too. So what's the optimal NNT? Well, it depends on what you're talking about in terms of the intervention and the outcome. For example, if you're looking at preventing death from jumping out of an airplane, your NNT for your parachute better be 1, right? If it's not 1, we're in trouble. And if somebody came out with a new parachute, you know, new AI developed parachute that had an NNT of 2, it would not sell well. It would not be a popular parachute, right? So NNT, anything other than 1 doesn't fly there. But if you're talking about Plavix versus aspirin for secondary prevention of stroke, the NNT is 200. So you can debate about how cost effective that is. But if you had a new agent, you know, new fancy ticagrelor type drug that had an NNT of 50, that would be fantastic. That'd be amazing in that setting. It'd be a big hit with an NNT of 50. So what should be the NNT for endovascular therapy? Well, let's think about this. We know a lot about the pathophysiology of stroke. And if you have a large penumbra, you're going to get a small NNT. If you have a small penumbra, you should still treat the patient, right? The NNT won't be quite as great, but you should still treat them. But if you have no penumbra, my argument would be that we don't want to reperfuse people with no penumbra. This is a resource-intensive, expensive procedure. And if there's nothing to save, why are we perfusing the patient? And then, more controversial is this issue that I have seen patients that I'm pretty confident were harmed by this procedure. And I think when you ask people who do it, many will admit that there are patients who did not do well because of this procedure. So who are those patients? I think patients with massive core and no penumbra are in there. And if you're treating all those patients, then your NNT is way too large. So what you really want to do is treat the patients in the green category. And if you include all the green patients, you should have the optimal NNT. So now is the question for the audience. What is the optimal NNT for endovascular therapy? I've got 3 choices, 2, 5, and 10. How many people think 10 is the best NNT for this procedure? How many people would go with 5 as the best NNT for this procedure? And how many people would say 2? Okay, there must be a lot of other choices because we got a few low hands over here. The periphery of the room, the penumbra was not voting. The core was saying 2. Okay, so let's think about this. And this is, I think, a perspective that many people don't think about when they tell me that the NNT of 2 or 3 is way, way too low. So if we asked you, our endovascular folks, what's your TICI 2B3 rate? I think a reasonable number we might get from the crowd is 80. Would you agree with that? Yeah, 80. So if 80% of the time we have substantial reperfusion, shouldn't close to 80% benefit from our treatment? Good outcome rate in Mr. Clean was 33%. Okay, so I think a lot of patients should benefit, and I think that this is a phenomenal procedure. It's incredibly effective, and we should not accept large NNTs. And in fact, if you do the math and you say, I'm going to reperfuse, substantially reperfuse patients, and absolutely agree, TICI 3 is way better than 2B, but 2B is significant reperfusion. If I brought 40% of the patients to the lab with salvageable tissue and I reperfused 80%, that'd be an NNT of 3. And I think we should be able to do a whole lot better than 40% of the patients that I send to the cath lab having salvageable tissue at the time of reperfusion. What if 50% of the patients that I sent to the cath lab had salvageable tissue, substantial clinically relevant salvageable tissue at the time you pulled off that TICI 2B3? That NNT would be 2.5. And if 60% of the patients had salvageable tissue at the time of reperfusion, that NNT would be 2. So this is why I don't like the idea that we should accept the NNT of 8 from Mr. Clean. I think we should be heading to 2. And I would like to even be better than 2. If I can reperfuse 80% of my patients, I would love to have 75 to 80% of those patients benefit. All right, so we go back to where we were in the earlier talk and say the world exists of patients who have salvageable tissue and can have big benefit. Some who have less salvageable tissue can have small benefit. And this red zone of patients who I believe are harmed or at minimum have no benefit. So these are patients with massive core, they've got no blood volume in the stroke, or they've got no penumbral tissue. And even if you have a neutral to negative effect in that red zone, you can still have a positive trial, right? Because the green and yellow zone is bigger. So if I treat all of these patients, I'm going to still get a positive trial because the benefit is so huge in the green and yellow zone. Does that mean I should treat all the patients? Some people say yes. I don't think so. If we can clearly identify who's in that red zone, why are we doing a resource-expensive procedure? But just the point is that you're going to still get a statistically positive trial when you mix in patients who don't benefit if a substantial number have a huge benefit. And we have a treatment that has a huge benefit. Okay, harm. So one of the reasons that we hear that there's no harm is that when you look at the Rankin 5 or 6 rates from any of these trials, you don't pick up harm in the overall trial. But just as we've discussed that there's people in different zones, you can have 15% of your patients in the red harm zone where you actually increase death and disability by maybe 20%, but mix that in to all the good patients who are having a substantial reduction in death or disability, and you can wind up with a neutral or slightly positive risk reduction on death or disability. Does that mean we should treat everybody? No, we should identify who's in the red zone and not treat them. So who's in the red zone? Let me give an example of Mrs. Jones, 58-year-old woman. She's one of these typical patients where you don't really know when the stroke occurred. Technically, she's a wake-up, but the story was that at 7:15, she was doing some of her normal activities, but we don't really know when the stroke began. She can't tell us. Her NIH is 13, her aspect score is 7, she's got a right MCA occlusion. So she may be early window, she may be late window, but her aspects is 7. Should we treat her? How many say yes? Okay, a lot of people say yes. How many people say no? She could be late window. We don't treat late window by aspects of 7, but what if we got more information? So here's some more information, a CT perfusion that says her core estimation is nearly 200 mLs. And she's got no blood volume in her infarct. She was treated. The hope was that after the procedure, this was a lot of contrast, but it was blood. So she was harmed by this procedure, in my opinion. And we've seen people harmed by this reperfusion in the past. Diffuse 1 in 2006, diffuse 2 in 2012, no target mismatch. The reperfused patients did worse than the non-reperfused patients. And here in 2018, the SELECT trial, which took a big cohort of patients, got CT and CTP, found patients who had a good aspect score, just like Mrs. Jones, but a bad CTP. Their mortality was 50%, their symptomatic intracranial hemorrhage rate was 25%, and if their core was over 100 ml, their mortality was 70%. Contrast that with the patients who had a good CT perfusion, but a bad aspects. They had a low aspect score, but a good CT perfusion. These patients did quite well. So here it is graphically. On the right, unfavorable CTP, but a favorable CT, just like Mrs. Jones. Very unfavorable profile of outcomes, whereas the patients who had a favorable CTP, even if the aspects was low, they look like the patients who had good CT, good CTP. So too little, too much. Get enough so that you know who's got salvageable tissue, and try to reperfuse patients who have completed infarcts or at very high risk for reperfusion hemorrhage. Thank you.